glaucoma drainage devices in children, I think majority of the precautions that you would take and the technique that you would follow has already been discussed. And I will highlight a few modifications that we would possibly do in a child. So this will be the outline of my presentation. So when we looked at the profile of childhood glaucomas in our country, whether it was the study that we did in LV Prasad or the study that we did across the country, we know that close to half of the pediatric glaucomas that we see are secondary in nature. Because these secondary glaucomas can be very, very refractory, so they also require additional interventions in the future, or sometimes they may require a primary tube implantation. And of course, even with primary procedure, primary glaucomas where the primary procedure is not a tube, but with time they do fail and one may require to do an implant procedure. So we know that in primary glaucomas, the initial surgery of choice is an angle-based procedure or a combined trabeculotomy with trabeculectomy, but in difficult situations or when the primary surgery fails, will require a GDD implantation. So why I would like to emphasize this is that the primary implantation of a tube in a child is something that we definitely want to discourage. So some people think that if they have a very, let's say a primary congenital glaucoma presenting with a 14 millimeter corneal diameter, that means it's a very severe disease to begin with. Maybe the angle-based surgeries or maybe the combined trabeculotomy and trabeculectomy don't work and hence we would go in for a tube. I think that thought process is not right, because the more difficult, the larger the globe is, the more difficult the eye is. For a tube also, it's not safer to be placed, and also remember that this child has a long life to live. So you wouldn't want to do a tube as the primary procedure in them. You would want to definitely think of doing something else that can probably bring down the pressures to some extent and for a few years, and when that fails, maybe you'll think of doing a GDD implantation. So just to reiterate the fact that it's a severe disease at presentation, this is a baby who presented with a grade 4 corneal edema. A combined trabeculotomy and trabeculectomy was done, and this is the kind of corneal clarity that you see with a couple of HAB striae and well-controlled intraocular pressure. So it is possible to control the intraocular pressures with the conventional procedures that we do, even if the presentation is quite severe. On the other hand, this is something that I learned. So we used to do, like, this is a child who underwent a CTT and the pressures were controlled reasonably well. So when you do an EUA and you see that the pressures are borderline, let's say 20 to 22 millimeters of mercury, you can say that maybe because there's corneal scar, you're recording a higher IOP, multiple things that we talk about, and this child was actually suggested an additional intervention because the pressures were not controlled, and the child was actually awaiting a corneal transplant. But to our surprise, after we did the tube, you see the kind of corneal clearing that is there, except a tiny little scar that was there in the center. To a great extent, this edema along with the scar can come down when you bring down the intraocular pressure. You know how the IOP is measured. Under anesthesia, you are underestimating, and also in the presence of a corneal edema or scar. So this doesn't hold true the way it is in an adult. You may be underestimating the IOP. All you have to do is bring down the IOP, and this child does not require a corneal transplant. So in children, the ball game is completely different compared to what you see in an adult. So primarily, to me, it is the intraocular pressure control that's utmost important, and tubes definitely have a role to play in bringing down that, additionally bringing down the intraocular pressure, and we can prevent a corneal transplant in many of these patients. So GDDs, we do have valved and non-valved implants. Basically, all the GDDs that we have has an intraocular portion, which is the tube that acts as a conduit for the fluid to reach the anterior chamber into the posterior subconjunctival space. In children, the problems that are special are they have very thin sclera, especially if you have a very large eye. The globe is stretched from the cornea until the entire sclera. They have a large eye for the orbit, so we have to worry about the space as well. And also remember, the child's eye is going to grow as the child is going to grow older. So the length of the tube that you place in the anterior chamber is also something that you should account for the enlargement of the eyeball as well. A meticulous preoperative preparation and planning is very, very important, not just for an adult, but for a child, it's even more important. Choosing an appropriate type of implant, size of the implant, location of the implant, and positioning of the tube is something that is very, very critical. And all of us who do implants in children will definitely agree that one has to be very, very meticulous, not just with the surgery, but also about the planning. So these are the two choices that we have. The main difference being in a non-valve device, you are, because it is non-flow restrictive, you are using a flow restriction, whether it is the tube ligature or with or without a supramid. And of course, today we don't do it without a supramid at all. So it has to be a double kind of a ligature or a flow restriction that you would require. So often when we do implants in children, so one step that I do differently, like even in adults, I use a 24 gauge needle for a tube entry, and I additionally use a patch graft apart from using a 4 millimeter long or a 5 millimeter long tunnel. Even in the presence of a scarred cornea or a hazy cornea, you will still be able to place a tube if you use a light pipe, or if you have an endoscope, you can use an endoscope to visualize the tube. The one step that is different in a non-valved implant in a child is that, apart from, like I said, supramid is also used. That's a transparent supramid that I had used, and of course you also do an additional tube ligature. So one, I don't know if that step was very clear. I'll replay this video here. Is that when I'm using a supramid and I place it subconjunctivally, I make a small track with a 26 gauge needle and place the edge of the supramid in that track, so that it's not placed subconjunctivally. In a child, you need to be even more careful. So beyond the scleral patch graft, I make a tiny little opening to, I think there's a video that I will show up later. So there are several indications that we have discussed about. And if the child is especially awaiting a corneal procedure at a later time point, you can definitely plan to do a tube implantation. A pars plana tube, especially in the presence of a corneal graft, I think is very, very useful. And any pars plana tube insertion, like what Indira discussed, it has to have a complete pars plana vitrectomy and not a limited anterior vitrectomy to just place the tube, because at a later time point you can have a tube block. So we need to be meticulous with that. Length and position, like I said, I think I would like to reiterate that as the child's eyeball keep increasing in size, the length can shorten. If you need to leave a little longer tube, make a parallel entry over the iris, so it's almost parallel to the limbus over the iris. So if I do the same surgery today, what you see there on the circle, I would place it even more parallel to the iris. So this was an older picture that I have taken in a child. So if you want to leave the length of the tube a little longer, don't make it perpendicular to the way we normally do. Even in adults, we have moved to making a parallel entry, so that becomes very important. So you can leave it a little longer rather than a short tube. So the other picture that you see is aniridia. We always used to worry about what if the tube touches the lens and the patient may develop a cataract and things like that. Nothing will happen, believe me. All you may have is possibly a localized cataract, even if it is literally hitting on the lens, and nothing else will happen. So avoid placing it close to the cornea. That is the most important one. But a little longer tube over the iris, or even if it is touching the lens, nothing will happen. Tube corneal touch, we need to be very, very careful. So a tube position, even though you have placed it well behind the cornea, it is going to be a dynamic movement, especially if the child is going to rub the eye. So be very, very careful. And in a vitrectomized eye, if you are placing a tube, whether in the pars plana or in the anterior chamber, it's okay. But in a non-vitrectomized eye, especially if it is aphakic, if you have little bit of vitreous in the pupillary plane or just behind the pupillary plane, I would always suggest do an anterior vitrectomy, because it may not appear as if the vitreous is going to block the tube now, but at a later time point when the fluid is flowing, you may have vitreous that can block the tube. So these are few things that you need to remember. Of course, hypotony has significantly come down with the help of a supramid. This is the tunnel that I was just showing. Maybe I can replay it. This is a very simple step, but that's extremely useful. So make a tiny tunnel and place the edge of the supramid there, so that it is in the subconjunctival space, but the tip of it is not subtenons, so that it may not erode out, especially in a child. And of course, the other complications we need to be extremely careful about. Any area of conjunctiva that has a small opening, or if there is a tube erosion, one can lose the eye, and especially in a child, if they don't allow you to examine in the clinic, we should not hesitate to take them up for an EUA to evaluate what's happening. So any inflammation, any redness when the child is brought into your clinic, and if the child has an implant, be very, very suspicious. You may want to do an EUA or a sedated examination to make sure that you're not missing out on anything. How do they fare? They do fare well, but like any other intervention, with time, every device has a tendency for the success rate to come down, or they fail because of fibrosis, be it a valved implant or be it a non-valved implant, whether it is in a primary setting or in a secondary setting. This is the long follow-up, I think the longest follow-up that we have with non-valve devices by George's group, where they've shown that close to about 40% fail by about 4 years. So the longer you follow them up, there is failure that happens even with non-valve devices. So remember, and that is precisely the reason why you don't want to use this as a primary surgery in situations where some other procedure is possible to do or some other technique is possible to do. And this is one thing we were just discussing about, especially in a child. Infranasal location is not something that you would want to use. Supratemporal is definitely the primary position of choice. And if a second intervention is required, like we just saw, a supranasal location may be something that we should think of. And if a GDD fails, we remember that for me especially, I wouldn't do a second implant straight away. I would do a repeat trab in some eyes where I have had my tube failed, or an angle-based surgery, or a limited transcleral cyclophotocoagulation before I would take it up for a repeat second GDD. So second GDD in a child, I think you need to be extremely careful. If I've exhausted other choices, only then I will go in for it. Otherwise, remember, there are two hardware sitting in a child's eye and you never know how long the second implant is going to work as well. So I think we need to be very, very careful. So childhood glaucomas are definitely a challenge, and tubes are very useful, but I think remember the long-term problems and complications and long-term success as well in these eyes, and we need to be careful in choosing the interventions and following them up long-term. Thank you so much.
Thank you very much, Sirisha. And I just wanted to reiterate that one of Sirisha's slides showed a completely opaque cornea. If a tube has to be done, you'll be surprised with IOP control, some kind of peripheral clearing do occur, and patient has some kind of ambulatory vision. Another tip, what Sirisha said, touching the lens, nothing happens. Even touching the iris, nothing happens. Even if the tube is touching the iris, there's a small focal atrophic spot that remains there.